Hi, I'm Lindsay Mabry. I'm going to talk to you today about cardiogenic shock. What is cardiogenic shock? It is decreased cardiac output and evidence of tissue hypoxia in the presence of adequate intravascular volume due to heart damage. Cardiogenic shock is the leading cause of death in acute myocardial infarctions and has a mortality rate of 70 to 90 in 70-90% in patients not receiving aggressive care. Patient assessment for cardiogenic shock. Symptoms: hypotension, absence of hypovolemia, poor perfusion, skin is ashen or cyanotic, and extremities are malted and cold. Pulse is rapid and faint, and it may be irregular due to arrhythmias. Jugular venous distension can be present. Crackles may be heard in the lungs. Peripheral edema also may be present. Heart sounds are usually distant. Patients are usually tachycardic, altered mental status, decreased urinary output. Patients may develop systemic hypotension, which is where the systolic blood pressure is below 90 millimeters of mercury. To diagnose cardiogenic shock, the following tests may be performed: biochemical profile, a CBC, cardiac enzymes, arterial blood gases, lactate, and brain natriuretic peptide. Imaging. Echocardiographs should be performed as soon as possible to determine the cause of the cardiogenic shock. First, you treat the cause to fix the shock. Chest x-ray findings are usually for excluding out other types of chest pains and the other types of shock. The coronary angiograph is urgently indicated in patients with myocardial ischemias or MI who have developed cardiogenic shock. Hemodynamic monitoring and findings. Swan-Ganz catheterization is used to rule out the other types of shock. The hemodynamic measurements of the cardiogenic shock are the pulmonary capillary wedge pressure is greater than 15 millimeters of mercury. The presence of large V waves on a pulmonary capillary wedge pressure tracing suggests severe mitral regurgitation. High right-sided filling pressure in the absence of an elevated pulmonary capillary wedge pressure when accompanied by an ECG criteria indicates right ventricular infarction. An arterial line may be placed to provide continuous monitoring of the blood pressure. Pharmacological treatment of cardiogenic shock. IV or central line fluid resuscitation to correct the hypovolemia and hypotension. Unless the patient has pulmonary edema, do not do fluid resuscitation. It can cause more damage. Give aspirin and heparin if the patient has an MI or acute coronary syndrome. Inotropic and or vasopressor drugs therapy may be given to the patient with inadequate tissue perfusion but has adequate intravascular volume, and this is just to maintain the mean arterial pressure. Dopamine is the drug of choice. It improves cardiac contractility for the patients who have hypotension. It may also increase the oxygen demand. Dopamine is started at a rate of 5 to 10 micrograms per kilograms per minute via IV. The rate is adjusted according to the blood pressure and other hemodynamic parameters. Patients can get a dose as high as 20 micrograms per kilograms per minute of dopamine if needed. Dobutamine may be preferred over dopamine if the systolic pressure is higher than 80 millimeters of mercury. Compared to dopamine, dobutamine has less effect on the oxygen demand, but dobutamine can cause tachycardia. Norepinephrine, the dose for that is 0.5 micrograms per kilograms per minute, and it's normally titrated to maintain the mean arterial pressure, and they like that to stay about 60 millimeters of mercury. The dose for norepinephrine, it varies from normally about 0.2 to 1.5 micrograms per kilograms per minute, but it can go all the way up to 3.3 if needed. Arterial blood gas and mechanical ventilation. Arterial blood gas values indicate overall acid-base balance and the level of arterial blood oxygenation. A base deficiency range of +3 to -3 correlates with the occurrence of this and severity of the cardiogenic shock. Mechanical ventilation is normally required. However, it is important to remember that positive pressure ventilation can help with the oxygenation, but it can decrease the venous return to the heart, which in turn will cause your patient more harm. Thank you for watching.